All right, everybody. Well, good morning. So thank you so much for joining us for our session today. So this is part of the medical education series by the Medina Clinic. And the goal of the Medina Clinic, or its mission, is a couple of things. One is to provide charitable primary medical care to individuals who otherwise don't have insurance and would have a hard time accessing that care. And the other part of our mission is in the process of providing charitable medical care to afford opportunities for aspiring practicing physicians to get clinical skills, improve their knowledge, and advance in their careers. So we want to be a place of learning and a place of charitable medical care. So this is part of our medical education series for individuals for their medical school rotations or other rotations. As far as our participants today, here are our participants. So my name is Dr. Murad, and I'm with the Medina Clinic. So I'll be facilitating our discussion, and other participants are Dr. Abir El Sheikh, who is from Illinois, Dr. Tahani, Dr. Tahani, how do I pronounce your last name?
Abu Juh.
Juh?
Yes.
Very good. So Dr. Tahani Abu Juh from Iowa, Dr. Varda Chowdhury in New Jersey, and Dr. Bami. Dr. Bami, how do I pronounce your last name?
Oduwole.
Oduwole, also from Illinois. So welcome, everybody. So our topic today is the physician-patient relationship, okay? Now, this is sort of part of our series thus far on family medicine, which you'll notice is really, it's really related to communication, community health. These are the types of topics that we're focusing on right now, because these topics are not that easy to learn right off the bat. I think in terms of like the organic diseases, the actual clinical care, these are very important, and we may include this in our series at some point. But the behavioral and communication and community aspects of being a family physician, I don't think there aren't a lot of opportunities to review them, and they're very important, actually. You can be a really good clinician, but if you're not good in this other stuff, you're not going to be a good family physician. So that's why we're focusing on these topics right now, and they are uploaded to YouTube, so you guys can always go back and take a look at previous sessions. So today's session is the physician-patient relationship. And this is a key one. Actually, I'm surprised I didn't review this earlier, to be honest. This is a very, very key topic. You can be an excellent clinician, but if you do not have the skills to engage in an optimal way with your patient, your clinical care can only go so far, basically. So, all right, guys. So let's look at our first. Case here. Okay, so you have a 42-year-old gentleman who has been, your patient for 4 years, and comes to the office for a routine office visit. And I should mention Dr. Bami. Dr. Bami is one of our assistant physicians. So Dr. Bami actually sees patients at the Medina Clinic. So Dr. Bami may have some of these cases resonate with her, because she'll see that people come in for their annual visit, and it may resemble a lot of these cases. So, okay, you have been treating chronic migraine headaches for the patients. He mentions that he would like to see a neurologist who he heard speak on the radio. Although you have done a complete evaluation of his headaches, he is concerned that he might have a brain tumor or other disease. And I think this is a pretty common case actually, where you have patients who come in with headaches, they get frustrated and they say, I want an MRI or I want a neurology referral or something like that. Do you guys experience anything similar?
When patient present with upper respiratory infection, they insist to get an antibiotic.
Sure, exactly. Excellent example. Thanks, Dr. Abir. So let's look at our questions. And the title of the case is, I trust the doctor, but, I still want what I want. So let's see. Okay, so considering the situation, what should you do? Should you and explain to the patient that you have investigated the condition completely and that there is no need for a referral? Or would you B, tell the patient that if this is the way he feels, he should probably just get another family physician? C, empathize with the patient about his symptoms and refer him to a neurologist of your choosing? Or D, empathize with the patient about his symptoms and refer him to the neurologist that he mentions? Or E, tell the patient that you are deeply offended by his request. He has no right to question your competence. Okay, so what do you guys think?
I go with A.
A, okay.
There is no need for referral.
Okay, so we have 2 votes for A. Anybody else?
I will go for A2.
A, okay.
I will also go with A.
A, okay, sounds good. All right, let me give it a shot. And again, I don't know the answers ahead of time, so I'm going to be taking it with you guys. All right, so A, explain to the patient that you have investigated the condition completely and that there's no need for a referral. It certainly sounds reasonable, so I'll put a pin in that. B, tell the patient that if that's the way he feels, he should find another physician. Yeah, that seems a little aggressive. So I think A would probably be better than B. C, empathize with the patient about his symptoms and refer him to a neurologist of your choosing. Yeah, it's always good to empathize, And it's actually interesting. A, it starts off with the word explain. That's good. B, tell. That sounds very, very patriarchal almost. So B, the way it starts off doesn't sound so good. C and D, they both start off with the word empathize. If I just look ahead at E real quick, tell the patient that you are deeply offended. He has no right to question your competence. Well, I don't know if that's exactly true. So I don't like E. So far, A is better than B and E. So now if we look at C and D, it's always nice to empathize. Refer him to a neurologist of your choosing. Refer him to a neurologist. So you guys liked A over C and D, huh? Yeah.
Because question already says, it's been, there's nothing to investigate. There's no need.
Right. It's a good point. And it says here in the question, it says, considering the situation. And if we look at the situation, he just says he wants to see a neurologist. Yeah. And when you look at C and D, what's the difference between a neurologist of your choosing and a neurologist he mentions? I don't know. There might be another question about choice, but choice of specialist, but maybe C and D aren't that different. Okay, I'll go with A2. All right, let's see what the answer is, shall we? So number one is number one. Oh, you guys, the answer is D. The answer is D. All right, so let's see why. Let's see what it is that we missed, shall we? All right, so very interesting. So unless there is a specific reason not to, you should refer to the patient to the neurologist of his choice. Patients with chronic symptoms are difficult to manage. You may find that a second opinion not only validates your findings, but also improves the relationship between you and the patient. He may, in fact, find the headache to be less of a problem. In this case, it would prove to be less of a problem for both you and him. So that's the information. So I guess what I should have probably done is I should have probably thought about what I actually see in clinic. You know, I should have probably thought of it that way. And you know, when a patient does come, and I'll tell you, I've definitely had the situation before with chronic headaches, actually, specifically. Actually, I've had 2 patients in the last 6 months that I can think of. One patient, one patient, it's fine. You know, we haven't had to refer to a neurologist. And what I did with that patient is I sort of said, I left it open about the possibility of a referral down the road if things don't get better, you know, almost in a way to head it off. There's another patient so that first one, she was an older and a more elderly lady. The second one was a younger guy, like a college age, maybe even high school age male. And for him, it wasn't so much a referral as it was imaging. And you know, I think there will be another question coming up on imaging later. I hope so anyway. But in general, when a patient says, I would like a referral, in general, and I really should have thought about this a little bit more, really just thinking about actual patients. But when a patient says, I want a referral, you usually don't tell them no, really. Okay, so when a patient wants a referral, that's in general, that's what they want. I mean, that's what it is that they're saying that they want. And to deny a referral, I don't think is very productive. I should have thought about all this before I answer the question, but it's kind of counterproductive, and it doesn't exactly help with the physician-patient relationship. The patient, I would imagine, sometimes may even get the impression of, what is it that you're trying to hide? And actually, when, like with that one first patient, where even leaving it open for a neurologist later, you know, is to show that, you know, we have a plan. But also, I guess that really was to head it off. I guess when you know, if you convey to the patient that absolutely we can do a referral, that actually shows confidence in what you're doing. So I think that's important to convey. So in practice, when a patient says, I want a referral, I can't think of a situation where I just say, no, you don't need it. You know, that's not really something that I say. So yeah. And even in like I'll share something with you that my advisor told me in residency. Let's see. Yeah, I'll share with you something my advisor told me, which is, you know, if you see a patient a number of times and the issue is not getting better, you should even offer a referral even. I think what he advised me was, if you're seeing a patient for something and you saw them 3 times and nothing changed, nothing got better, absolutely no progress, nothing like that, you should refer. So so anyway, those are some things that come to mind with this question. What do you guys think? Sound good?
Yes.
Yeah.
Do
Okay.
you guys have any other patients that come to mind when reading this question? Nope. Okay, well, let's move on to the next one. Okay. What is the primary purpose of consultation or referral to a specialist? All right, so we were just talking about this. Is it A, to validate the findings of the family physician? B, to ensure that the family physician has not missed anything? C, to provide reassurance to the patient that the family physician is concerned about his or her welfare? Is it D, to improve the quality of healthcare by making available to patients and referring physicians the knowledge and skills of specialists or consultation at appropriate times? Or E, to provide protection for the family physician against a malpractice lawsuit? What would you say? No thoughts?
Thinking D.
B and D sounds good. Let me see.
I'm confused between A and C.
A and C,
I choose D.
D. Okay, so we got a lot of, we got A, C, D. Okay, so kind of a number of different options. Did anybody not vote yet?
I'm thinking.
You know what we should do? We should have like an electronic thing where we pick the answer and then automatically display the results. I'll think about that for future sessions.
I'm between A and C.
A and C. Okay, let me give it a shot. So, okay, the primary purpose of consultation or referral to a specialist: to validate the findings of the family physician. So yeah, that can certainly be the case. B, to ensure that the family physician has not missed anything. Yeah, that one I get a little bit nervous about. I think when I refer to a specialist, and we talked about this actually in an earlier session a couple of months ago about consultation and team-based care, there are certain etiquettes when referring to a specialist. So to refer to a specialist to just make sure I didn't miss anything is not really consistent with the best way to reach out to a consultant, I think. That's not a good use of their time. Usually when you reach out to a consultant, it's to say, I have a specific clinical question. Here's everything that I've done. Here's the situation so far. Here's my specific clinical question, or here's what I think the patient needs that only you can do. Like if you're a surgeon or if you do a certain procedure or something like that. So in a nutshell, that's how you engage with specialists. But to say, here, I just want you to see this patient. I just want to make sure I didn't miss anything. That'll drive a specialist crazy, actually. So B, I don't particularly like. We'll put a pin in A. C, to provide reassurance to the patient that the family physician is concerned about his or her welfare. Yeah, that's a pretty resource intense way to reassure the patient that you're concerned. So C, I'm not that crazy about. D, to improve the quality of healthcare by making available to patients and referring physicians the knowledge and skills of specialists or consultation at appropriate times. So D, I like. D, I like for a number of reasons. First of all, if you notice, it's the longest answer, right? It's the longest answer out of these. So if you have no idea what to pick, in this case, D is a good one because you see how much longer it is than the other answer choices. But then but more importantly, it talks about the you want to improve the quality of the care. And that's really why you're referring to a specialist, is because the clinical care, you want it to be like, quality is a good word. You want it to be appropriate. You want it to be timely. You know, you want the patient to get what they need. That is good quality. So to improve the quality, that's consistent with why I refer to specialists. to take advantage of their knowledge and skills. That's the thing about a specialist. The specialist has expertise and specialized expertise and specialized knowledge in certain things. You want to take advantage of that by asking a specific question, or maybe they need to do a specific procedure. That is why you engage in a specialist. Whatever a specialist does, it needs to be worth their time, because they have this specialized expertise. What they're doing needs to make use of that specialized expertise, not just to make sure you didn't miss anything, you know? So it's worth their time if it makes use of their specialized expertise, all right? So that I like it for that reason. And then at appropriate times, you know, like a bad way to use a specialist is if you have a patient and you're like, I don't know what's going on, let me refer you to a specialist. Well, that's ridiculous. What you need to do is you need to work the patient up. You need to evaluate the patient. You need to narrow the differential. And then if there's a specific clinical question that a specialist could help with, then you engage the specialist or you refer. So that you want to do it at the right time, where after you've evaluated the patient and you've done everything you can. So yeah, D, I just like. To provide protection for the family physician against a malpractice lawsuit. So I think in general, we don't do things to avoid a lawsuit. That's not why we do things, really. I mean, you know, sometimes when working through a differential, you know, medical legal things may be a consideration to guide, you know, how to develop a plan of care based on your differential. Like if you have something on your differential that's life-threatening, well, you know, then your plan of care may take that into account. But you don't just refer just to avoid a malpractice lawsuit. So that's not something you really do. So I like D. Okay, so let's take a look here. So 2 is indeed D. Yay, I got one right, you guys. All right, so let's see here. So the primary purpose of consultation or referrals is to improve the quality of the healthcare by making, you know, just what the answer is. Oops, sorry. There we go. Okay, so that's the purpose of consultation. I feel like that whole 2-hour session we did on team-based care was just summarized just now, to be honest. Okay. So there may be situations and complicated cases in which you wish to validate your findings or make sure that nothing has been overlooked. There also may be times when patients need additional reassurance. To refer to specialists for the sole purpose of protecting yourself against malpractice, especially on a regular basis, is inappropriate. Can I tell you guys a story? One time I was moonlighting in the emergency room, and I was a resident. Okay, so in residency, a lot of times you can moonlight. So I was moonlighting in residency in a small town emergency room, and I remember there was just a lot of lower extremity injuries that were coming through. And with these lower extremity injuries, of course, I got x-rays, and I was a resident, and that wasn't something I was as comfortable in as maybe other x-ray imaging. And I remember what I did was I wanted to make sure, literally, I wanted to make sure I wasn't missing anything on the x-ray. So I just wanted to, this was a long time ago when I was in residency. So just wanted to mention that. So I would get the x-rays, and then you know what I would do is there was maybe like 3 patients in a row or something like that I got x-rays, I think, of ankles, feet, things like that. And this was this was before my podiatry rotation. So then I would actually reach out to the radiologist on call to make sure I wasn't missing anything. That was very inappropriate. And he told me too, actually. He was specific. He said, it's not appropriate to reach out on every imaging. And then I was like, I'm sorry, I apologized. And I stopped doing that. So that was a situation where you are reaching out to the specialist because what? One, I wanted to make sure I wasn't missing anything. That's B. The other is I was worried about medical legal implications. So that was avoiding a lawsuit, right? So as a resident, that's what I was doing. I was doing B and I was doing E, and it was not appropriate. It was not appropriate. And so I stopped doing that. And I just made sure that, I got comfortable reading those x-rays. So specialists, it'll drive them crazy. So do you guys have any experiences about something similar? Well, our group is very quiet today.
My kids are here yelling, so I don't want them to disturb. That's why I'm on mute.
Okay.
They are going crazy.
That's okay. All right, well, let's move on to number 3. Okay. Trust in one's physician is described by patients as, this is an interesting question. Is it A, an inherent personality trait, B, having no relationship to institutions with which the physician is associated, C, a learnable skill that can be improved, D, separate from competence issues, E, different from being a quote unquote good doctor? What would you say?
What about C?
C, okay. We have 1 vote for C. Anybody else?
I go with C2.
C as well, good. We have 2 votes for C. Anybody else?
Yeah, I'm also going to C.
Okay, another C. Okay, we have
Same
4.
thing, yes. See,
C, okay.
I never said that.
All right. Okay, I think I might agree. So is it an inherent personality trait? Yeah, so you're kind of skeptical about that. B, having no relationship to the institutions. So I would that's not consistent with my experience. I think patients, the relationship with their institution is very important. There's the name brand of the organization you work for. Sometimes patients have experiences with the front desk, maybe good or bad. They may have experiences with the billing office. Maybe it's an organization that's close to them. Maybe they've been going to the organization for 30 years and they've had different doctors. I think that usually patients, the organization that they go to is a big reason, it's a reason in addition to the provider as far as why they go there. C, a learnable skill that can be improved. So that's consistent with my experience in residency. So in residency, you're learning, right? And, you're learning how to be confident. You're learning how to be competent, right? You're learning how to be a good doctor. So you're, and I recall that there was a learning process and you got better in terms of establishing rapport with patients and establishing trust that patients have in you. So to me, that resonates. D, separates from competence issues. So, I think that patients will not know if the medication you're prescribing for them is exactly right, or they won't know if the lab or imaging that you're ordering for them is exactly right. So they are not they're not the best judges of your clinical competency, I think. But I think that's a far cry from saying that they're separate. So if you're incompetent, you're incompetent not just clinically, but you're also incompetent professionally. Maybe you don't get back to the patient in a timely fashion. Maybe you don't respond appropriately to the patient's questions. I think that there might be some other professionalism issues that play into it. Maybe you have horrible bedside manner. That's a competence issue. So to say that it's separate from competence issues, I don't think is true. And then different from being a good doctor, I think kind of the same reasons, So I would go with C. So your answer is C. Good, you guys got it. So, let's see. So as outlined in the Cochrane Review by McKinstry, patients refer to learnable skills and not simply personality characteristics. Although competence is part of trust, it is not the full determinant of trust. So any comments on this issue? Anybody?
No, it's clear.
Okay. All right. So let's move on to the next case. You can be a tool for change. Okay. So, I want to say that as a family physician, I think this is definitely true. So I also remember in residency, one time I had a patient who came in and she was morbidly obese. And what we did was we, when talking with her and counseling with her, we counseled her about, having, just focusing on one simple regimen every day, which in her case was just walking actually. And what happened was from like week to week, and she followed up like every week, and her weight just dropped. It just dropped a lot. So and especially with your EHR, you can print out, graphs of their vital signs and labs and things. So there was just this drop in her weight from week to week, and it ended up being like a dramatic slope. And so I remember at one point I was checking out to my attending on how she was doing, and I printed it out. I was being a good resident, was trying to be a good resident, and I printed out this chart, this line graph. And oh man, my attending, she tried to hide it, but man, yeah, she was impressed. So it's like don't fail me from a residency. I was just a tool for change for this patient. So so it's definitely true. Being a family physician does give you a lot of opportunity to make changes in the patient's life. So don't ever underestimate that. All right. Do you guys have any stories on how you felt like you changed a patient's life, like by lifestyle or anything like that?
Yeah, regarding smoking cessation.
Oh yeah.
And counseling the patient with the effect of smoking in his body,
Yeah.
risk factor for many diseases.
Right.
Dr. Umar, mine was at a methadone clinic. This patient had difficulty showing up every time. So I tried to speak with him and I realized he didn't have the transportation to come. So I got involved with the social security and the charge arranged that. The doctor I was assisting was so proud of me because he never thought of it that way. Like, sit to the patient and ask, why are you not showing up? Does this patient really want the methadone clinic thing to work for him? He just wouldn't show up because there's no transportation. So the doctor was so surprised I could figure that out, and I, just placed the call and everything went well from there.
Wonderful. Yeah, you see, that was an excellent examples, or some excellent examples. Very good. Very good. So yeah, go ahead.
Yeah, I had a patient with the juvenile diabetes. He wasn't complying with the medication because he was like 15, and he had a notion that I'm like my friends are not taking any medication, so why should I take? Like it's like he was a kid, so it was a hard case. But eventually, after a lot of discussion and giving him example of a lot of like famous people who had juvenile diabetes, he became compliant. But initially when he came, he used to miss his medication and he was very offensive, like he was very against taking it. So
Right.
I encountered such case. Yeah.
Wow, what an excellent example. So you use some other role models. You
Yes.
introduced other role models for him aside from just his friends. It sounds like so.
Yeah, he was interested in cricket, like sports. So I gave him an example of a famous cricketer who had this problem, and I just tried to explain it to him like that's normal and it can happen to anyone. And then eventually he became compliant to the medication.
Wonderful, wonderful. Well, that's great. Yeah, these are the things that make you happy to go into medicine. I feel like if you go, sometimes the other professions, I feel like they may not give opportunities like this. So that's wonderful.
Exactly.
Yeah,
Yes.
cool, great. Okay, well, somebody else have one? Okay, just didn't want to interrupt anybody. All right, well, let's take a look at our second clinical case problem. So you can be a tool for change. All right, so a 56-year-old female patient had been diagnosed with type 2 oh, there you go, doctor. Diagnosed with type 2 diabetes here several years earlier. She had great difficulty maintaining her weight and medication schedule. She often denied that she needed to remain on the regimen recommended by her physician. Each visit, the physician would spend time discussing the importance of lifestyle and adherence to medication programs. Okay. I will say that one thing at my organization that we have is we have integrated behavioral health. So we have behavioral health clinicians to help support the providers when it comes to issues like this. So when it comes to behavioral or lifestyle changes, that are necessary for successful management of a patient's chronic condition, we have this extra support staff to help devote time to addressing this with patients. So that's something that we have that we think is helpful. Okay. So the patient's relatively long relationship with her physician is likely to what? Is it A, enhance her ability and commitment to follow the treatment plan? B, overburden the physician and encourage him to refer her elsewhere? C, have no influence on the treatment process? Or D, allow her to feel less guilt over her non-adherence to the plan? Or E, enable her to set her own treatment regimen? What would you say?
Thinking A.
A, okay, got one vote for
It
A.
should answer ability. So
Yeah, I
What's
will
that?
go for A.
Okay, hang on. So who said A?
Ayo, Dr. Bam.
Dr. Bami.
Me,
Me,
Rabi,
Tahani.
Hani.
Okay, so I think I counted 3, I think, for A. Anybody else?
Yeah, me too. A.
Okay, got a little bit of a consensus. So let me give it a shot. Enhance her ability and commitments. Yeah, that sounds good. B, overburden the physician and encourage him to refer her elsewhere. The long relationship, I don't know about that. That's not really consistent with what I experienced. Have no influence on the treatment process. No. D, allow her to feel less guilt over her non-adherence to the plan. Really? A long relation? So I would think patients may feel the opposite. If they have a good relationship with the provider, they may feel that, they may feel more guilt because they know the provider and they may not want to disappoint the doctor. To say, going back to C, to say that a long relationship has no influence on the treatment process, I don't think is appropriate. And then E, enable her to set her own treatment agenda. So that's interesting. Let me look at the case again. She often denied that she needed to remain on the regimen recommended. So, okay. Huh. So I think I like A better than B, better than C, and better than D. It's just E. Enable her to set her own treatment agenda. So, I think sometimes, patients having leeway or influence on their treatment regimens is reasonable. Yeah. To remain. And the patient just flat out says she doesn't need to. And then the physician would spend a lot of time. So it looks like they're doing this. The physician and the patient are just sort of butting heads. Yeah, enhance her ability and commitment to follow. The thing is, she's just not, A sounds good, but it's just that they're doing this all the time. Yeah, or enable her to set her own treatment agenda. Yeah. Enhance her ability and commitment to follow. The thing is, I just don't see, the only thing about A is I'm not seeing where that's going to happen, because it's just the same thing every time. Enable her to set her own treatment regimen. Yeah. So I do feel that there are times when, sometimes it needs to be modified for what the patient can do. So I feel that there's some aspect to that for E. Enhance her ability and commitment to follow the treatment plan. It sounds good. I might be overthinking it and get it wrong anyway, but yeah. I mean, maybe eventually. It's just that it says enhance her ability and commitment to follow it. Is that likely to happen? That's the thing. Is that likely to happen? And for me, I'm just not sure if that's likely, because it's just, she's just had a lot of difficulties with it. And she often denies it. Like she says, she is explicit. She says, I don't need to do this. You know what I mean? Like she says, I don't need to do this. Yeah, I think because for me, I'm not sure if it's likely to change. I'm not sure. And I feel like there's some component in E that is valid. So I might go with E over A in this case. All right, guys, ready to see the answer? All right, let's take a look.
Yes.
4. Oh man, you guys were right. See, that's what I get for disagreeing with you, huh? So it is A, actually. So evidence suggests that patients, so let's see why I was wrong and why you guys were right. So, oh, by the way, I do want to mention, I have passed my family medicine boards fine, in case you guys are wondering. So don't worry.
Congratulations.
So, all right. So evidence suggests that patients who have continuity with and trust in their physician are more likely to be adherent to the agreed on treatment plan. The relationship serves as a positive reinforcement in care of chronic disease. Although progress may be slow, having a continuity relationship increases the likelihood of ultimate adherence to the regimen. So I think So that's pretty much what you guys were saying. I think I was probably just impatient. So if I try and think of actual real life patients, to be honest, I should probably, that's one of the most valuable ways to answer these questions, is to just think about a patient. So there was one patient I had. She was, let's see, she basically had, what was the situation? We basically saw her in the office. She was following up from the emergency room or something like that. And she was diagnosed with AFib, okay? So she was diagnosed with AFib. So then when looking at her medication list, she's not on any what? Well, if she's on AFib, what should she be on? Let's say it's chronic paroxysmal AFib. What should she be on?
You mean like a blood thinner?
Yeah, she should be on a blood thinner. So she should be on some sort of chronic anticoagulation, and she wasn't. And then she said something about, oh yeah, the cardiologist said I should be on that, but I don't like him and I don't trust him and I'm not going to take it. Okay. So, so it was like, yeah, that doesn't sound like, I don't think we should do that. So I'm her family physician, and I had the opportunity to see her for a few visits. Okay. And so I said, okay, well, let me get old records, right? Let me get old records. Let me see exactly what the cardiologist recommended. That's why old records are so important, because it's not so easy sometimes to speak with the specialist directly, especially if they're not in your institution. So I got old records, and in reviewing the old records, it says that she was recommended to be on chronic anticoagulation. So I'm like, okay, I mean, personally, to me, she should be on chronic anticoagulation. I have documentation from her cardiologist saying she should be on chronic anticoagulation. So then it's time to talk to her. So you say, listen, this is the situation. This is the condition that you have. If it's not treated appropriately, you're at risk of a stroke in the future, and you have grandkids, you know, you're trying to maintain your quality of life. And I confirmed with the cardiologist that you should be on anticoagulation. And what the patient said is, I don't, you know, being the family physician, you have an opportunity to establish a relationship with her. So what she said was, I don't like him. Do you think I should be on chronic anticoagulation? And I said, well, yes, I do. I do think you should be on it. You know, I think you should be on it. And I see that the cardiologist corroborates that. And especially with his, in this particular case, you know, his expertise, this is what his opinion was. So I see no reason to disagree with this. So she says, okay, because you said I should do it, fine, I'll do it. So fine. Then later, she was, you know, several months later, I think she was hospitalized, and then the cardiologist said that she needs a cardiac catheterization. And, or no, what happened? Oh, no. She got a stress test in the hospital. And then she was telling me in the office that, yeah, they did a stress test and the stress test was abnormal. And they were telling me I need to do a cardiac catheterization, but I did not like them. It was a comment. And by the way, this is her relationship with that institution. Remember how we were talking about a relationship with institution? She did not like that institution at all. She did not like that institution, and that, I think, spilled over into her relationship with the specialist. So she said, they told me I had to do a cardiac catheterization, and I didn't like the way that they talked to me, and they said I had to do it, and they didn't give me a choice, and I didn't like that. So I left and I didn't do it. So I did the same thing. I got records, confirmed that yes, the stress test was abnormal. Yes, they recommended a cardiac catheterization. So when talking to her, I said, yes, you need to get this done. So then she said, fine, because you said I need to get it done, fine, I'll get it done. But I don't want to go to that same institution. So fortunately, she had insurance. So it was like, fine, let's refer you to a different institution so you can get this done. And she did. We referred her to a different institution. They saw her, she got her cardiac catheterization done, and that care was complete. So that was an example of someone. This is a situation where, you know, I don't know how long of a relationship that I had with the patient, but it was more than the specialist, that's for sure. So that longitudinal relationship I had with her at the end, interestingly, because I mean, even when I'm talking to her, at first she was telling me, no, I don't want anticoagulation. No, I don't want a cardiac catheterization. No, you know, and then finally she said, fine, if you say it, fine. And so eventually it enhanced her ability and commitment to follow up with the treatment plan. That's what ended up happening. So, do you guys like this? I get the question wrong and I think of a patient that justifies the answer. Do you guys like that, how that works?
Yeah, I think all about trust, building trust and explaining to the patient everything.
Exactly. Yeah. And then that was, you know, that part of it was the relationship she had with our institution, because she was seen at our institution for a while. She saw another doctor, that other doctor came and left, and then I started seeing her. So even though maybe I was not seeing her for a terribly long time, maybe like a year, so it wasn't a terribly long time, but she had a relationship with our institution. So maybe that helped as well, you know? So it was just very interesting to see how she came to how she eventually developed a commitment to the treatment plan. So, okay, guys, let's move on, shall we? So trust in one's physician contributes to. Why don't you guys look at that? I am going to plug in my laptop. I'll be right back.
I will go with D. Improved treatment adherence.
Yeah, me too.
All right, guys.
This is D. Improved treatment adherence.
What is it?
D.
D.
Yes, D.
Okay, any other
I'll go
vote?
with D2.
Got
D.
2 for D, anybody else?
Yeah, D.
Yeah, D.
Okay, it looks like it's pretty unanimous. Okay, trust in one's physician contributes to discontinuity of care. Don't think so. Usually if patients, if they trust you, then they will keep coming back to you, you know, because of that trust. So I don't think A. Patient dissatisfaction seems kind of an odd, you know, why would trust result in dissatisfaction? I'm not sure. C, elimination of the need for second opinions. No, I think, you know, second opinions are there for, you may need them for very valid reasons that have nothing to do with whether they have trust in you. Improved adherence, I like that. More frequent office visits. Yeah, how interesting. You know, Yeah, I think when you have more frequent office visits, I think it could be a function of other things. Sometimes it's for dysfunctional reasons. So not so sure about that. So I would agree with D. So the answer is, I don't think there should be too much controversy here. So yep, it is D. So there was a Cochrane review, just so you know that there is evidence behind this. There was a Cochrane review by McKinstry that notes that trust can increase patient satisfaction, improve adherence to treatment regimen, and improve continuity of care. So very good. All right, so that was a pretty straightforward one. Okay, moving on. So trust is defined as, what would you guys say?
B.
Okay, B, we have one vote for B. Anybody else?
E.
Okay, one vote for E, good. Anybody else?
I go with E2.
Okay, one more.
Everything makes sense. I'm gonna go with E.
Okay, all right. So trust is defined as, let me take a shot at it. Taking the physician's word for recommended treatments. Yeah, I feel like that it ends up being that way because I think patients, they're not good judges necessarily if you prescribe the right medication or something of that nature. So I feel like that happens. B, expectation that the physician will put the patient's interest first. I do think that that is the case because, you know, that is, I feel like that's the point at which patients trust you, is when they feel that you are, you know, genuinely interested in them doing well. So I like B. C, belief that the physician will not allow insurance incentives to influence him or her. So that's interesting. Yeah, I mean, I'm not sure how often this comes up, but I wouldn't discount it. If I had to pick one, you know, I would take A or B over C if I had to pick one. D, assumption that all consultants to whom the physician refers have the same perspective of patient care. Interesting. Yeah, very interesting. Yeah, so when this happens, okay. So when when you refer, then the patient assumes that you're referring them to someone who's also very good. You know, so it is true that patients do make assumptions. When you say I'm referring you to someone, they're like, oh, well, my doctor cares about me. They're referring me to someone, so I'm sure that this person must be very good. So I think that that's reasonable. So, so I think that I would probably be inclined for E because they do seem reasonable. Okay, guys, ready? Let's see what it is. So 6. Wow. You guys, I'm too influenced by you guys. You guys vote a certain way and I just go with you. Believe it or not, the answer here is B.
Wow, my answer.
You got it. Who got that? Dr. Abir?
Yes.
That's why you just be independent, Dr. Abir. That's the way to go. So look at that. Look at that. So, and you know what? In looking at this again, its trust is defined as, it's like a definition. So probably should have read that more carefully. Yeah, I should have read that more carefully. So 6B. All right, let's look at the information here. Although patients interpret trust as belief or confidence that the physician will provide reliable information and will act in the patient's interest, it does not mean that patients should not ask for further information or seek to confirm the reliable information, okay? So I guess trust but verify, basically. And I guess that's another good point, actually. That's another good point because, you know, they, it's not that they don't believe you, but maybe they're going to check with another source to make sure, you know, just to double check what you're saying. So that would have been a better way to interpret it. It creates an atmosphere in which patients can ask about influences on physician decision-making, such as choice of inpatient facility or type of insurance incentives, but it does not ensure that physicians would not be affected by external incentives. Okay. Yeah. You know what? I'll be honest. I need to read this again. Did you guys understand all that? Let me take another look at this. All right. So the first part that we got, I think we got that okay. You know, it does not mean that patients should not ask for further information or seek to confirm the reliable information that is provided. Okay, so it doesn't mean that patients can't check what you say. So it doesn't mean that they don't trust you, but you know, they may want to do that. But again, it doesn't mean that they don't trust you. So that's why A is not it. But it says it creates an atmosphere. What's it? It creates an atmosphere in which patients can ask about influences on physician decision-making, such as choice of inpatient facility or type of insurance incentives, but it does not ensure that physicians would not be affected by external incentives. You know what? I should have thought about this a little bit more. So the thing is, it's like, belief that the physician will not allow insurance incentives to influence him or her. You know, the thing about that, and I should have thought about this a little more. The thing is, you may very well be influenced by insurance incentives because a lot of times those insurance incentives are geared towards better outcomes. So why wouldn't you be? It's not a bad thing. It's not a bad thing necessarily that you would be influenced by insurance incentives. So that's not necessarily, it doesn't necessarily mean that you're not trustworthy. What do you guys think about this? Hello?
Yeah.
Yes.
What do you guys think about this? Do you guys agree with this answer?
Yes.
Yeah. Make more sense.
Yeah. Yeah, I think that yeah, a patient can double check what you say. C, I'm not sure I understand it completely, but I think that you know, that's not how trust is defined, and it is possible you may be influenced by insurance incentives because they may be geared towards better outcomes. Let me see. Yeah, so I think trust that an atmosphere of trust would allow patients to ask about this, but it doesn't ensure that you're not going to be affected by insurance incentives. You know, so it's not consistent with the definition of trust, which is C. And then D, well, you know, it looks like that may not be, you know, universally true, I guess. So, okay. I mean, I think A and C for sure. After reviewing it, I would agree, it makes a little bit more sense. Okay, guys, do you email? So a couple and their 2 young children moved to the West Coast because of job requirements. One of the first things that they must do is find acceptable primary care for the family. They have come to appreciate the flexibility of having a physician who is willing to use electronic communications. As they search for a physician or a group that will support their needs, they outline the following concerns. All right. So let me make sure they outline the following concerns. Let me make sure there wasn't more to this. Yeah, I guess we could just jump into the questions. So, access to e-health offers them, what would you guys say?
What about A?
Okay, we got 1 vote for A. Anybody else?
Yeah, I go for A too.
Okay, another one for A. Good. Anybody else?
I'll go with A too.
A. Good. 1 more.
I'm sorry, can we go back to the question again? I'm going to with A as well. I just would like to see the question. I need to get this right.
You're gonna go for A as well?
Yeah.
Okay. All right. I'm gonna try and be independent here. I'm gonna try and not go with the group. Let me think. Access to e-health offers them convenience. I mean, that's for sure. So the thing is, so currently, you know, in my normal job, what I do is I use something called the patient portal. So the patient portal is where we can send messages to patients. And if patients have an email, then they can get access to the patient portal. So I use my electronic health record to send messages directly to patients. But it not only can go directly to patients through the patient portal, but it can go to them by text message. And also it can go to them by voicemail too. So these are ways that we can communicate directly with patients, and patients can directly communicate back to us through the patient portal, and I get a message in my inbox. So this bi-directional communication with patients, I find it to be very helpful for patient care, and it actually keeps patients engaged in their care. So so this is a very if organizations are not doing this, they really should be. So if I think on that experience, I would say convenience. Sure, I think it is convenient. In fact, we encourage them to use the patient portal because it saves them the trouble of calling and leaving a voicemail and, you know, calling through the front desk and getting transferred. So I do think it is convenient. Control. Yeah, I mean, so, I mean, I feel like it does give patients a sense of control, in the sense that they're communicating directly with the doctor. So I feel like they have that, because that's one of the things we say. We say you can communicate directly with the doctor. So they say, oh, I can communicate with the doctor whenever I want, as opposed to someone else telling them if they can talk with the doctor or not. So I sort of feel like B I feel like that's there. Choice. Now, having said that, you know, yeah, I'm not sure about that. I mean, they're assigned a PCP. You know, I mean, you talk about choices of therapy. So it helps with communication. I'm not sure if it helps with choice exactly. So I have some doubt about that one. So that one I would put lower. So for me, I think where I'm at is I like A, I like B, C I have doubt about. So for that reason, I go with D. Okay, that's my effort to be independent. You guys ready to see the answer?
I'm thinking of E too.
E, oh, we had somebody that went for E. Okay, I was thinking D personally, but someone likes E, huh? Okay. Number 7 is E. Who was that?
Yeah.
Wow, look at that. Amazing. Amazing. Good job. Good job. So you changed it and you got E. Good job. Wow, I'm doing terrible in this section, I have to say. So, all right. So number 7E, let's see what the facts are. So convenience has never been more important with 2 parents working. Oh, that's right. And of course, we have to think, we're thinking about this case as well. So convenience has never been more important with 2 parents working and increased commitment to free time. Dealing electronically with appointments and answers to brief questions is more convenient than telephones and wait times. Okay, so the convenience part we've established that. Having the ability to make their own appointments or request a refill at 2 a.m. allows them to have more control in the negotiation of receiving care. Okay, so that's a good point, where they can send a message and they don't have to wait for office hours. Maybe, and we get this a lot through the patient portal, where patients are requesting refills. So they can request that refill in the middle of the night if they want. And so that gives them more control. So an increasing amount of disease management can be done online as well. Allowing the patient with chronic disease to work with the physician to manage blood glucose levels or blood pressures without having to make frequent office visits. So I'm not sure if that talks directly about choice, though, is the thing. So I'm not sure about that. Interestingly, where in this did it talk about choice? Without having to make frequent office visits. So we talked about that, yeah. We talked about convenience. We talked about control. So I guess when it talks about choice, it's talking about, I guess what it's getting at is that, you know, a patient has the choice to deal with their chronic medical condition online, or they can come in to get it. They can come in to discuss it. So it gives the patients more choice to how to get their care. They can walk in, they can, you know, communicate through the portal, or maybe they can even do telemedicine. That's another form of e-health, by the way, is telemedicine. So in that way, it can provide more choice to patients. So I guess that makes sense. Do you guys have any experience with the patient portal or telemedicine?
Yes, I have experience with patient portal. It's more convenient, yeah.
Yeah, tell us about your experience. What kind, like what was it exactly?
Yeah, if I need any refill for medication, I just email through the portal, or if I want to check on the lab results. So all of them I can find all my visits summary or something like that, or my kids in the portal.
Right.
Very helpful, yeah. Instead of waiting and call the office and ask the nurse, yeah, just log into my portal and find every information there.
Wonderful. So you can see the benefits of eHealth from a patient perspective.
Yes.
Okay, perfect. Good. Anybody else have experience working with patients by patient portal or telemedicine or anything like that?
Yes, I did. It was like the main job was to call the patients and then take the history and enter it in the patient portal, and like recommendations, even referral were done through that. So it was part of the tele-rotation actually.
Wonderful, wonderful. Good, good. Okay, excellent. Yeah. So the patient portal and eHealth, it is a key component of the physician-patient relationship. All right, guys. Okay, next question. Soon after the couple selects a physician who is electronically savvy, so there you go, they chose, there's an example of choice, I guess. One of their children develops a significant asthma attack with very rapid breathing, wheezing, and some blue discoloration around his lips. They immediately email the physician's office for instructions. So, which of the following, I guess, is true? A, this is unacceptable because emails should never be used for an emergency. B, the physician's email has a header instructing that if the query is an emergency, the patient should call 911 and not use the email contact. C, the patient signed a release form in the physician's office indicating that she understood the email address was for making appointments, follow-up visits with brief questions and the like, and should not be used for emergent issues. D, the couple take their child to the nearest emergency department and on returning home, use the physician's email to provide his office with an update on the emergency department visit and request for a follow-up office visit. Or E, all of the above. What would you say? What would you pick?
D, the couple take their child to the nearest emergency department, and on their way they update it.
Yeah, I go with D too.
Okay, we have 2 votes for D. Okay, anybody else?
What about E?
Okay, got 1 vote for E. Anybody else?
I'll go with E too.
Another one for E. Good. Okay, so let me give it a shot. This is unacceptable because emails should never be used for an emergency. So this is a very strong word when you say it's unacceptable, but in this case, it may be warranted. Bluish discolor, I mean, so basically the patient has central cyanosis, and when you have a child with an acute asthma attack and you're developing central cyanosis, that is a full-blown emergency. So when we say it's unacceptable, that to me, that feels appropriate here. The physician's email has a header instructing that if the query is an emergency, they should call 911 and not use. I think that's probably, I mean, that's appropriate. I wouldn't see any reason to doubt how appropriate that is. The patient signed a release form in the physician's office, so that should be true as well. You know, there should be those consents and disclaimers that are signed ahead of time. D is definitely true. That's exactly what should happen. They should go to the emergency room right away and then notify the physician through the patient portal when they get back and letting them know that they need a follow-up appointment. That's a very appropriate use. So to me, I have no reason to doubt any of these things. So I'd probably go with E. All right, let's see. 9 is, you know what? What was the last one? The last one was number what? Last one was number 8. I feel like I skipped a question. Oh, you know what? I did skip a question. So 9 is E, yes. I gotta go back to 8. Oh yeah, sorry guys, I skipped a question. So 9 is E. Let's take a look. So the email option, okay. So the email option offers a great deal of convenience to patients and physician offices. It is flexible with regard to the timing of queries and answers, allows detailed information to be attached to the answers, and allows a ready record of the interchange. However, it is not appropriate for emergency situations. It is imperative that physicians who provide email interface for their patients take steps to ensure that at the time of an emergency, email will not be used, although it does provide a way for timely update to a physician of other emergency interventions. So that all makes sense. Any questions on this one? Has anyone ever had a situation where they sent a message to a patient, or a patient sent them a message in an emergency?
No.
Yeah,
No.
I think most patients probably know, but not always. So sometimes patients will say, it's interesting that they use here an asthmatic attack. I feel like the times where that's happened with me, patients will say, I'm having trouble breathing. And it's like, yeah, maybe, or maybe it doesn't need to go to the emergency room. But like when someone says I'm having trouble breathing, like, and they're waiting for instructions from the physician's office, which may take like a day or so, it's just, it's good to have these things in place so that patients are aware. All right, let's go to number 8. So the e-health options can affect the physician-patient relationship by A, causing greater disturbance because there is less face-to-face interaction. B, improved sense of commitment because the physician can send reminders or quick pre-programmed questions about how a patient is doing. C, creating patient dissatisfaction because physicians answer emails at unacceptable times of the day. D, reducing liability risk by keeping a copy of physician-patient interactions. What would you guys say?
I'll go with A.
A, okay, got 1 vote for A. Anybody else?
We'll go for E.
Got 1 for E. Anybody else?
I'll go for B.
I'm sorry, B?
B, yes, B, yes.
Okay.
It has to be.
Got another one for B? Okay.
Yes.
All righty. So I'll take a shot at it. Greater disturbance because there is less face-to-face interaction. Actually, I think the opposite is true. I think you cause less disturbance because it's good to have interactions to supplement the face-to-face interactions, actually. So to be able to communicate with patients outside of an office visit is actually very helpful. So A does not strike me as the answer. B, improved sense of commitment because the physician can send reminders of quick pre-programmed questions about how the patient is doing. I do think that there is something to that. I think when patients get, because patients, when they get communication from the physician, it's a big deal. So when they get messages from the physician, it's evidence of their commitment to the patient, because the patient values that kind of communication a lot. So B strikes me as correct. C, so I like B better than A for sure. C, creating patient dissatisfaction because physicians answer emails at unacceptable times of the day. You know what? I've never really had that be an issue with patients because patients, first of all, they know that doctors are busy and they do work, doctors do work at unacceptable times of the day. And I think patients are generally understanding of that. And also, if a doctor sends a message to a patient, then usually it'll be in the inbox when the patient sees it the next day. And so that's, you know, it's not like the patient is being disturbed in the middle of the night or anything. Having said that, I am careful when I send messages to patients. I don't send things, I don't send like a voice message to patients in the middle of the night so their phone doesn't ring. So that's something I guess to be careful about. So anyway, C does not strike me as true. So B, I like B. A and C, I'm not so sure about. D, reducing liability risk by keeping a copy of physician-patient interactions. That is definitely, I feel, true. So when I interact with a patient, all those messages are stored in the patient's medical record. So when I explain things to patients, when I offer them choices, when I offer them treatments, when it's documentation that I am communicating with the patient, you know, that I am engaged with the patient, all those things reduce liability because it's there written. So if a patient says, well, no one ever told me this, or that was not communicated, that's not true, it's in there. So all these interactions with patients, they're all documented in the chart. So it is it actually, because you have more robust documentation, it actually decreases liability for the physician. So D, I think, is definitely true. So I like B, I like D, so I would just naturally go with E. Let's see what the answer is. So the answer here is indeed E. All right, so let's see what the facts are. So the increased frequency of interactions, okay, the increased frequency of interactions allows patients to feel greater physician commitment, even though the physicians are, or the interactions are not face-to-face. The flexibility of sending both queries and answers at times that are convenient for the patient and physician improves satisfaction. There is evidence that liability is actually decreased because there is an easy record of the question and subsequent advice that may not exist for phone interactions. So there you go. Any questions on this one?
Yeah.
No, it's clear.
I'm sorry, did someone have a question?
No, I said it's clear. Sorry, my son talking.
No problem. Okay, guys. Very good. Let's move on to the next one here. So clinical case 4, communicating for continuity. A 52-year-old white man presents to your office with prostate cancer. It has been previously treated with surgery, and his primary care physician has been following his PSA test results. He has moved across the country for job-related reasons and is seeking a new primary care physician. Okay, I feel like this happens a lot. You know, I'll have patients that will see and they say, oh, like there was one patient recently, she said, oh, I moved to Texas. By the way, I moved to Texas. Can you please send these prescriptions to this pharmacy in Texas? So the patient portal allows patients to communicate easily that way. So number 10, communication with cancer patients is particularly problematic because A, it is always bad news. B, patients must process complex and at times controversial information. C, all cancer patients maintain strong hope for a cure. D, the physician-patient trust relationship has implications for the patient's adherence to follow-up and treatment. By the way, I don't think we're necessarily on the topic of patient portal and eHealth anymore, just FYI. What would you say?
E of D.
Okay, so I heard 1 for D. Anybody else? Did I hear
E.
1 for A?
E,
Okay.
the last one.
I'll
Okay.
go with
E as well.
I'll go
Okay.
with E.
Okay, I think, okay, this is what I heard. 1 for D, 3 for E. Did anybody say anything different? No? Okay, let me give it a shot. Communication with cancer patients is problematic because it is always bad news. Well, I don't know about that. I don't think that's true. And it says always, you always want to be careful about that. So I wouldn't say A. Patients must process complex and at times controversial information. I think when it comes to cancer patients, I can see how that can be problematic. So I kind of like B. So I'll put a pin in that one. All cancer patients maintain strong hope for a cure. I'm not so sure about that. And I don't even think that's my experience, to be honest. I don't think that is true of all cancer patients. So I don't particularly like C. And then D, the physician-patient trust relationship has implications for the patient's adherence to follow-up and treatment. I do think that that's true. I do think that that's true. I think, there was one patient with breast cancer that we diagnosed not too long ago. And, our recommendations went a long way towards, towards her getting the treatments or getting plugged into the right specialist. So I like D. So I think I don't have any reason to doubt B and D. So I would go with E. Let's see what the answer is. All right, the answer is E. So E, let's see here. According to the National Cancer Institute at the National Institute of Health, cancer patient communications are particularly problematic because the caregivers must help patients receive bad news, handle the emotional impact of a life-threatening illness, deal with uncertainty while maintaining hope, and understand and remember complex information, communicate with multiple health professionals, that's for sure, and build trust that will sustain long-term clinical relationships. Many cancers are curable today, so not all news is bad. However, despite great progress in treating cancer, many patients have difficulty maintaining a positive, hopeful attitude. So, okay, that's pretty much consistent with what we thought. So let me ask, who answered D?
Yeah, me.
Okay.
Fine.
So Dr. Tahani, so what were the thoughts that you had in mind when picking D, and maybe B? What gave you doubt about B? Because there may
I
be a
feel
lot.
that B is strong, like must.
Was that?
I feel that more. I feel B is more defensive, like must process or.
Oh, yeah.
I excluded it.
So you felt that the wording was kind of strong here.
Yeah.
Yeah. I think I think the probably your most common strong words are always and never. Always and never. Those are definitely red flags. Yeah. Process complex. Yeah, must process complex and at times controversial. Yeah, I can see how that, the word looks kind of strong, but I think always and never are your big ones. Always and never are your big ones. Going back to this other one where it said unacceptable, even unacceptable, In medicine, there are a lot of things that are unacceptable. So it is strong, but especially when we're talking about emergencies. So to me, unacceptable looks kind of strong, but it's reasonable in this context. But always and never, I can almost never think of a time that that's the correct answer. We'll put it that way. So, but yeah, it looks like in this case, must may not be so bad. So, okay. All right, number 11. We're almost done, by the way. Patient-centered clinicians use the following behaviors. All right, what do you guys think? A, avoid eye contact because it threatens the patient. B, frequent interruptions of the patient to seek clarification indicate concern and commitment to clarity. C, calm listening with an absence of distracting movements such as fidgeting. D, avoid repeatedly asking the patient to provide feedback or tell the physician that he or she understands because this insults the patient's intelligence. E, lean back in the chair with arms and legs crossed to indicate that the clinician has all the time in the world. What would you guys say?
C, calm listening with C.
Yes, C.
Okay, I heard 2 for C. Anybody else?
I'll go with C too.
Okay, got another one for C. Anybody else?
C too.
Okay, consensus here. I kind of like C as well. So avoiding eye contact because it threatens the patient. So by and large, eye contact is a positive thing. And along with that, I try, I usually regret when I'm not sitting down talking to the patient. Sometimes things might be kind of quick, or you're going to pop in and out you're going to pop in for just a moment before you come back again, or something where, you'll be standing, and I suppose sometimes that's reasonable. But when really having a discussion, when having a meaningful discussion, I regret when I'm not sitting down. I think back on those times, I'm like, you know what? I really needed to be sitting down. So, and that is to maintain, when we talk about eye contact, to also maintain eye level, where your eyes are at the level of the patient's eyes. So, and that helps maintain good eye contact, actually. So I find that is very important when communicating with the patient, because I think sometimes when communicating with the patient, that information is challenging anyway. And so with these nonverbal communication styles, it really needs to support your conversation. So yeah, avoiding eye contact, I think in general is not good. You really need to look at, make that eye contact when having a discussion with patients, and also that helps you read the patient, because you can see, is what you're saying, is it connecting or not? And you can read that from the patient. So B, frequent interruptions. Look, I don't know when that's ever good. Frequent interruptions to seek clarification. I mean, really, to get clarification, you want to interject at appropriate times, and there are times you need to interject. But when we say frequent interruptions, I don't know about that. I actually think that hinders communication, and you actually may not get the clarification that you need. And frequent interruptions, I think for the patient, it doesn't really convey concern and commitment. It really doesn't. I think it indicates, like, if I'm interrupting frequently, it may indicate to the patient that I don't care about what they have to say. And that, how can that be a good thing? And if the patient feels that I don't care about what they have to say, it really doesn't, I'm really not conveying commitment to clarity at that point. So B, I don't like. C, absolutely. And I think sometimes, you want to be careful because you might be behind in clinic, you're pressured for time. So, you might be, it's possible you may be fidgety. And so you really need to control that. So emotional control is very important. So you don't want to be tapping your pen or tapping your foot, or like looking here and there, or looking at your watch, you know, or just appearing impatient. None of that is good. None of it is good. So calm listening without those distracting movements are important. D, avoid repeatedly asking the question to provide feedback. So I think that I would disagree with D. I think that that is important to do. So to ask the patient, what do you think about that? Does that sound good to you? Do you feel like you can do that? You know, that to me is a way of soliciting feedback from the patient. And you know, and to ask the patient, do you, and some, you word it some way, but do you does that make sense? Do you understand? Maybe having the patient repeat back to you what your instructions are. These are all important tools, communication tools to enhance communication with the patient. So yeah, I don't agree with D. E, lean back in the chair with the arms and legs crossed to indicate you have all the time in the world. I don't know about that either. You probably don't have all the time in the world. You know, I think the optimal posture for nonverbal communication is eye level with the patient, maintain good eye contact, you know, leaning somewhat forward to appear engaged, make sure that you're listening. If you it's not like you can never interject, but just don't, you know, interject, try and make it at appropriate times. Make sure that you've listened to the patient, you've gotten in some listening, just get in some listening. And we all understand being pressured for time, but get some listening in, try not to interrupt the patient. And if the patient goes on and on and on and on, then you can interject at an appropriate time. So anyway, I agree with C. Let's see what the answer is. All right, good. We're ending on a good note here. So C. So let's see what the facts are. So good patient-centered behavior includes maintenance of eye contact and seeking evidence that the patient understands by feedback of what has been said. Listening without interruptions sends a message of interest, and clarifying questions can come at the end. Okay. Crossed arms and legs often indicate a closed mind or barriers to a relationship. That's a good point too. Yeah. So crossed legs, I think that's probably something I need to watch out for. But yeah, crossing your arms. So that is something just in general, whether it's for patients or anyone, if you're talking to someone and they have their arms crossed like this, what that indicates is that they are closed to what you're saying. And so if a patient is talking to me and I'm like this listening, even if I'm nodding my head and saying and you know, trying to give some verbal cues that I'm listening, if I have my arms crossed like this, that is strong nonverbal communication that I am not open to what they're saying. You'd be surprised on how much arms being crossed is a very telling indicator if the person is open to what you're saying. So I even overlooked that. So this is number 11, right? So crossed arms and legs often indicate a closed mind or barriers to a relationship. Calm listening without fidgeting sends a message that patients can take their time and tell their story. So here's the thing. When you're talking with a patient, you want to give them the feeling that they have been listened to, that they have the opportunity to talk. You may end up spending just a few minutes with them, okay? It doesn't mean that you are going to spend 30 minutes with the patient. You may actually end up spending 5 minutes or 10 minutes. The important thing is more quality than quantity, I think sometimes. So to give the patient the feeling that you are engaged, that you're listening, that they have the opportunity to talk and be heard, that is key when you give the patient that feeling. So let's say I go into a room and let's say I'm standing, for example. That's not good. And so let's say I'm standing and I'm talking down. Let's say I spend 15 minutes talking to the patient while I'm standing. I may have spent a good 15 minutes talking and having a discussion with them. But you know what? Maybe if my non-verbal communication is not good, maybe let's pretend I'm standing and my arms are crossed. Oh my gosh, that's terrible. So I can spend 15 minutes talking, standing, my arms are crossed like this. I would have spent 15 minutes, a lot of time, but they will feel that I did not communicate or spend time with them well, just because of that. But if I had great nonverbal communication, and maybe I even spent 5 minutes, they will be more satisfied with that. So, guys, have any questions on that? Do you guys have any experiences that you would like to share about, communicating with patients, whether good or bad?
Not a specific case, but always we have to treat patient with compassion and be empathetic.
Right.
And also we have to consider the patient, the diverse patient culture. Like eye contact, sometime in specific culture, they feel like this not a good introductory to the patient. Like we have to consider the culture too.
Can you give an example of that?
Like I hear that patient from Asia, I think they said when the doctor maintain eye contact, they feel humiliated, something like that, because in their culture, there is they consider eye contact something different.
Right.
That's all I think. Also, like shaking hand.
Right.
It is, it's built patient-doctor relationship, but in some culture, they consider different.
Right. Absolutely. Those are excellent points. Yeah, eye contact when it comes to different cultures, it may not be welcome. So that's a very important factor to consider, for sure. So that's one where you want to be mindful of. Do you guys have any suggestions on is that something that you would ask the patient directly, or is that something that you would clarify with the patients when talking with them, or like how would you work to get awareness of that?
So sometimes the patient mentioned that to medical assistant or the nurse first. Mm-hmm. And when I come to talk to the patient, I feel that maybe from the patient posture or reaction to that, I can ask her directly, do you feel comfortable? So I can sense that when talking to the patient.
Right. Yeah. So it sounds like, you could have your medical assistant or other staff kind of check on that for you potentially, or directly ask the patient. So yeah, that's those are some good suggestions. So anybody else have any patient experiences? So that was excellent. Those were very, very good points. Anybody else have any experiences they want to share about, the nonverbal communication sort of behaviors that they've demonstrated during office visits, if it worked well or did not work well?
I think for me, this was back 4 years ago when I was still a bedside teacher. This pregnant lady came in and she came with her husband. Can you hear me?
Barely, Dr. Babe, I could barely hear.
Oh, this pregnant lady came in with her husband, but he doesn't want her to be seen by a male physician, to do the physical examination for her. But they at the same time, they didn't want to say anything. So I think my friend, from their body reaction, their body language, he knew something was wrong. So he asked if I could just please help him see the patient for antenatal care. So they didn't say much, like I said, but their body language signified that the husband wasn't comfortable with the male physician attending to the wife.
Right. So this is where you're reading from the patients. You are reading from the patient's nonverbal cues. You know, if the patient is comfortable or not.
Exactly.
Exactly. Yeah. And that's a very good point because, you know, when you are communicating well with the patient, that means that you're also listening, and by listening, you're also listening to what they're saying, but also you're trying to catch. It's important for the doctor to catch these nonverbal cues as well, and because then you can miss something very critical like that. So that's a very important aspect to this also. Yeah, very good point. Good. Anybody else have any experiences they want to share? All righty, well, let's move on to the last case. So clinical case 5. All right, challenges of the online world. Okay, so a 56-year-old woman makes frequent visits to her primary care physician for complaints that frequently do not have identifiable organic causes. She often brings printouts from her forays on the internet, where she has researched her symptoms, medications, and possible interventions. Her physician becomes frustrated by her demands and diagnoses, medication, and laboratory or imaging examinations to identify causation. Let's see, by her demands, something doesn't seem right about the way that's worded. Hold on. Demands for, here we go. That makes more sense. Okay, her physician becomes frustrated by her demands for diagnoses, because sometimes patients say, I have this, you know. They will come in requesting certain medications. I remember one patient who came from out of state, and she gave a long list of diagnoses that she has. She gave a long list of medications that she was requesting. Demanding is probably a better word. Saying that these are medicines I've been prescribed by this wonderful specialist in the past. Laboratory and imaging examinations. Yeah, you'll have patients requesting different evaluations. So, and sometimes, sometimes the internet can exacerbate that, right? So before we go into the next question, do you guys have any experiences with patients coming in with things they saw on the internet?
A lot of patients come with these kind of like they wrote their symptoms on the internet, and they think they are suffering from a particular condition. So they have a certain notion regarding their condition.
Right. That's right. And so tell me, Dr. Varda, how do you approach that? How would you recommend, if you were talking to your colleagues and students, how would you recommend addressing that?
So I think we need to listen to the patient. We can never negate, or we can never say directly that whatever you're finding on internet is wrong, because the patient can feel offensive. But we can have a discussion regarding the symptoms and the way the patient is feeling, or the patient has a certain idea about his condition. So we can have a positive discussion regarding that, instead of just completely negating the patient's point of view.
Wonderful point. So the take-home message there is, is to try not to completely negate what the patient has is coming to you with, that they got from the internet, and maybe use it as a basis for a constructive discussion.
Exactly. Yes.
Very good. Okay. Anybody else have any suggestions on what they like to do in this situation? A patient comes in with stuff off the internet.
I have experience with patients who come to complain about they found terrible information regarding this medication side effect online.
Right.
And so I try to explain that. And yes, it is reported. I can't ignore that. But let us take it a number. So how many percentage of patients will develop this, or they may develop this side effect? So most of the time when I try to look at the literature and find the most reliable source to convince the patient. Most of them convince, yeah.
Wonderful, wonderful, good. Yeah, so basically, you take, so this is very common, patients, they come in with a long list of side effects from medications. Sometimes I've seen where patients, they come in, like you would prescribe, like you might prescribe amitriptyline for neuropathy, and then they come and say, this is an antidepressant. You prescribe for me an antidepressant, and other things that and it's not that they're wrong, it's not that they're wrong, but, they get some additional information that concerns them. So it sounds like what you're saying, Dr. Abir, is that basically you can help put those side effects, if they're coming in with side effects, help put that in perspective by talking about maybe the percentages of the times that they get those side effects. Is that right?
Yes.
Okay. Something that I will do sometimes is say that I'll say, in my experience, when I prescribe the medications, this is how often this happens. So I feel like patients, they value that. They value that real world experience that you have when you convey that to patients. So, so I'll do that sometimes as well when talking about the percentages. I'll say, in my experience, this happens less than 1% of the time that I've prescribed this, or something like that. So, okay, good. All right, let's do this question. So the appropriate steps for the primary care physician are, we should probably look at the case again. We don't want to forget about the case. So, oh yeah, this is our 56-year-old who comes in with stuff off the internet and demands diagnoses, meds, and evaluation. So the appropriate steps for the primary care physician are what? A, refer to an internist who will be more able to assign diagnoses to her complaints. B, avoid overuse of testing and reassure the patient that you will follow the symptoms closely with her to determine the correct time for intervention. Or C, prescribe an anxiolytic medication to help the patient remain calm. D, order a comprehensive chemistry and hematologic evaluation, followed by a PET scan to rule out any disease. Or is it E, none of the above? What would you say?
What about B?
Okay, got one vote for B. Anybody else?
I'll go with
Yeah.
B too.
Yeah, I'm also going to use B.
Okay, B. 1 minute. Was that?
Yes.
No.
B as well? Okay. Do we have a fifth vote? Sounds like we had a fifth vote for B. I'm just joking. So, okay. So let me take a shot at this. Let's take a shot at this. So A, refer to an internist who will be more able to assign diagnoses to her complaints. That's not necessarily true. If you arrive at a diagnosis based on clinical criteria, most of the time, the internist will probably agree, actually. So, and why will an internist automatically be more able to assign diagnoses, especially maybe you are more familiar with the patient? So, A, I have a lot of data about. B, avoid overuse of testing, and that is always good, okay? I think when you talk about patients like this, overuse of testing, it's very easy to fall into that. So, so to avoid overuse of testing is an important goal for a patient like this, and to reassure the patient that you will follow the symptoms closely with her to determine the correct time for intervention. And this may be what the patient is looking for, to be honest, to reassure that you will follow their symptoms closely. That attention in itself may be therapeutic. Prescribe an anxiolytic medication to help the patient remain calm. I have a lot of data about this one, obviously. You would prescribe an anxiolytic medication for a distinct reason, for a distinct medical condition. If they have anxiety, if they're having panic attacks, if they're claustrophobic or something like that. But just to remain calm in general, over, concerns about their medical issues that they researched, that just seems inappropriate. So C, I have a lot of data about. D, order a comprehensive chemistry and hematological evaluation, followed by a PET scan to rule out any other disease. And we see here that the patient frequently does not have any identifiable organic cause. So usually with a sufficient evaluation, if you have not identified organic causes, to continue to work things up just to make sure you're not missing anything, I think can actually cause more harm than good. And sometimes when you do an evaluation that is not indicated, you may end up getting incidental findings. And these incidental findings can create diseases in the mind of the patient. And it may lead to even more intervention that is costly and is associated with morbidity. So, there just is not a lot of virtue in D. Lab work, fine. I mean, you can, maybe talk about that. But getting a PET scan just to make sure you rule anything out, that it doesn't seem like appropriate use of resources. So again, that's in the setting of adequate evaluations in the past. So yeah, I would agree with B. Let's see what the answer is. Okay, it is B. Okay, so although avoiding overuse of prescriptions and testing can be very frustrating, the quality of the physician-patient relationship is particularly important in working with patients presenting with medically unexplained symptoms, okay? So this is the kind of patient where that relationship becomes key to management. Although patients seek a diagnosis, prognosis, and some form of action, a longer running relationship is more likely to provide a context of reassurance and watchful waiting. If non-action occurs in a setting without a relationship, the stage is set for patient dissatisfaction and overuse of medical services. Okay, I think that last sentence was particularly important. Yeah, if non-action occurs in a setting without a relationship, then that actually sets the stage for patient dissatisfaction and the patient going elsewhere where you'll have overutilization of resources. So I definitely agree with that. Yeah, I always think back to that patient who came from out of state with long list of demands. And, really that was someone where I feel like that relationship, I actually don't think I was able to establish a sufficiently longitudinal relationship with that patient to achieve the goals, regrettably. So I learned a lot from that. Do you guys have any situations similar to that? You have a patient who has multiple medical complaints, no identifiable causes, relationship was important to prevent overutilization of resources?
So while I was working in Michigan, my supervisor, he encountered a patient and he gave me a brief history about that patient, that patient had, she had a belief that she's allergic to a lot of things, even though she was not. So like he during the encounter, he listened to her all concerns, and then give certain suggestions and had a certain, like a little bit of discussion, and then he discharged her. So he said that, you don't have to perform a lot of tests in these cases, and secondly, you cannot refer these patients. Like, she was asking for another referral, but if you are sure that it's all in her mind, then you can build up a long relationship with the patient and avoid any kind of excessive testing or any referral, because that was a belief. She was having a belief that she's allergic to a lot of things, even though her blood test always came out to be negative.
I see. So this particular colleague was, emphasizing to not over order tests and to be judicious with the referrals.
Yeah, because the patient was continuously like asking, like, you send me to, like, I think he had sent her to a doctor once, the allergy specialist, but her tests were all like negative. Right. So he was a family physician. So he told me that the way to deal with these patients is to just discuss the like whole symptoms and provide reassurance.
Gotcha. Very good. And I feel like sometimes in the office there might be barriers to that, because there's when you're constrained with time, sometimes in the office that may not come to mind. I know I think about myself, and I think that for these patients, the right interventions, when I think about patients that I've seen, just like you were saying, Dr. Varda, the right intervention is to just have a discussion with the patient, just talk about it. And then, at the end, if you feel like it's appropriate, provide reassurance, and then maybe talk about how, this is something that we will definitely watch with you closely, leaving the door open in the future for action maybe. So yeah, that's a really good point. Excellent. Anybody else have any suggestions on how to deal with a patient like this? Anybody? Okay, well, let's move on to our last question here. So although being frustrated with the demands of this patient, you recognize that the use of the internet can do all of the following except. All right, so what does the internet do? Enhance the engagement of patients in their care by increasing their knowledge, reinforce the role of the physician as the ultimate source of medical information and the final decision-making source in treating an illness. C, allow investigation of difficult or embarrassing questions in a private environment. Or D, change patients from passive consumers to empowered participants who are more comfortable asking questions and discussing options. So the internet can do all of the following except. What would you guys say?
B.
B.
Okay, got 2 for B. Anybody else?
I'll go with B.
Okay, B. Anybody else?
Yeah, B too.
Okay. I think I might agree. So A, enhance the engagement of patients in their care by increasing their knowledge. It can. Definitely it enhances engagement, I think. B, reinforce the role of the physician as the ultimate source of medical information. I don't know how the internet does that. And the final decision-making source. Yeah, I don't know where that's ever the, sort of the stated goal. So yeah, B, I definitely don't like as much. C, allow investigation of difficult or embarrassing questions in a private environment. I do think the internet can do that. And D, change patients from passive consumers to empowered participants who are more comfortable asking questions and discussing options. I mean, I think that's true. So, and I think the question says, although being frustrated by the demands, you recognize that the internet can do these things. So I would agree that I feel like in my experience, it does do A. Now, what kind of knowledge? Knowledge is actually a very interesting word. You know, you can look up anything you want on the internet, but sometimes you have to have training and expertise to know what knowledge is valuable. So, so it doesn't talk about the quality of the knowledge, but it does increase information. I think information is probably the better word for me. But anyway, I think you know, I think A is true. I think C, it definitely allows that, where you can query things in a private environment prior to asking in a physician's office. And then D, for sure. I mean, I think that's probably the frustrating part about things, is that, you know, patients are armed with information. It may not always be the best information, but they're armed with that information and they are empowered, you know, and encouraged in a way to ask questions and discuss different options. So, and B just doesn't sound right. So yeah, I would pick B. So number 13 is indeed B. Good. So increasing research has demonstrated that of more than half patients who use the internet to seek health information, those patients benefit from increased knowledge and competence and engage more actively in the healthcare intervention. They often change from being passive consumers to more active participants as they feel more comfortable with participating as decision makers. Concerns have been expressed that physicians might lose their role as trusted advisors, but research suggests that internet users ask more questions and continue to seek out physicians as authoritative health experts, which I don't think we would think of necessarily. Evidence did suggest that the concern that some patients may create a burden by asking for tests, diagnostics, specialist consultations, and other interventions may be well-founded. Thus, even as physicians reap the benefit of a better educated patient, they will have to develop the skill of explaining why things should not or need not be done in a particular clinical situation. I think one thing that comes to mind too is, I don't know if you guys remember that one actor from Black Panther who died of colon cancer. Do you guys know which movie I'm talking about?
Yes.
So there was this actor who died of colon cancer, and there was some patients right after that, African-American patients, who came in saying that they want screening for colon cancer, and they were very young, like 30. Okay, so you know, saying I want a colonoscopy, you know, and for colon cancer screening, and you know, that was a situation where, you know, they look stuff on the internet. And that was a situation of needing to sit down and explain why colon cancer screening is generally not, you know, something that we would recommend typically in this situation. So anyway, but on the other hand, patients, they can go to good resources. They can go to the websites of healthcare organizations, or even the CDC or the American Academy of Pediatrics and things like that. And oftentimes these organizations like the American Academy of Family Physicians and the American Academy of Pediatrics, they have websites geared towards patients actually. CDC likewise has websites geared towards patients. So there are a lot of good reference you know, sources or sites that patients can get access to when they do use the internet. So there is that. Anyway, finishing this up here. Retaining the trusted advisor role is not the same as being the ultimate decision maker. Physicians must remain cognizant of and responsive to the preferences, concerns, and choices of the patient. Okay. Very good. So what do you guys think about patients and the internet? Do you guys generally feel it's good, not good?
You mean patient information or what?
Just in general, do you feel like your experience, do you have any experiences where the internet was a great help when you were taking care of patients, or did you feel like the internet really caused you more problems than good?
It's good in certain way that they come prepared, like they have like kind of an idea, but like if they overdo it, like if they come with certain belief, or if they think that they have already diagnosed their condition, so it can like kind of turn into a frustrating situation.
Gotcha.
They have already made up their mind, but
Right.
usually like they come up with good questions if it is done in a positive way.
Right, right. Makes sense. Okay, okay. Anybody else? Anybody else have any experiences they want to share about patients and the internet?
Yeah, my experience, I believe it is a double-edged sword. So sometimes it's help the patient to, I experienced that some patients, they look first at their symptoms in the internet and they come up with the differential diagnosis, and it's also help the physician. They become sure about, yes, I have this from this, and there is a lot of websites that advise the patient to prepare questions before going to visit the doctor. So it enhances this diagnosis process, but at the same time, at the extreme edge, it's harmful. Yeah, it's destroy patient-doctor relationship. It's usually, there is a lot of experience. So we don't have any control about it, but we have to advise the patient to go to trusted website that can help them and build a strong patient-doctor relationship.
Right. So what you're suggesting, Abir, is that there's probably an opportunity, if you know that the patients are going to use the internet, you can guide them by actually giving them some websites to go to.
Yes.
Yeah.
Even I in my area here, the doctors do that.
Right.
After they diagnose the patient, they give them some resources and website they can go and look at the information, and trusted information and helpful.
Right, right, absolutely. So that's how the doctor's office can use the internet themselves to enhance the physician-patient relationship.
Yes, I agree.
Yeah, good, good. Okay, good. Anybody else? Anybody else have any thoughts about the internet? Something that we haven't expressed yet?
Yeah, I used to work in a hemodialysis center, and I remember one time a patient said that he read on the internet that some herbs can treat his renal failure instead of dialysis.
Some what now?
Some herbs.
Oh, okay, yeah.
You want to use it and stop the dialysis.
So how did that end up? So what ended up happening?
I tried to convince him that not all like these herb are not approved, and that he needs the dialysis.
Right. Right. So you tried to counsel the patient. You tried to counsel them. They were getting some ideas about alternative treatments for the end-stage kidney disease, getting some alternative options from the internet, and so that was something you had to battle with, it sounds like, and to try and dissuade the patient from those options.
Yeah.
So yeah, I can see. And what ended up happening with that patient? Did the patient end up continuing with dialysis?
Yeah, he stopped dialysis for like 1 week, and then he came in like fluid overload and he needs emergency dialysis. Then after that, he stops the herbs and return back to dialysis.
Okay, so he ended up doing what he wanted to do, but then he developed complications. It sounds like.
Yeah. Yes.
Yeah, and sounds like ended up going back to dialysis.
Yes. Yeah. Exactly.
So what did the patient say anything when the patient came back to resuming dialysis? Did the patient say, "Oh yeah, you guys were right. I shouldn't have done that," or what did he say?
Yeah, he stops the herbs and he said that he will not go back to it like anymore.
Just not doing that again, huh?
Yeah.
Very good. Okay, let's take one more. Anybody else have any thoughts about patients and the internet? Who didn't go yet? Dr. Biemi, did you say something about patients on the internet or no?
No, I didn't.
Okay, well, Dr. Biemi, I'll go ahead and pick on you. What are your thoughts?
I think to me, I think it's a bad thing because patients come with so many questions, and like their mind is made up based on what they read off the internet,
Right.
So it takes a lot of effort to try to, reinforce what you want them to know.
Right.
I remember when I was in med school, I was at my rotations, I would have patients send email about, something as basic as their baby's weight, they want to know if that's the regular weight, and they keep calling and emailing and asking if you did read their message, but what you want to.
Yeah.
And they're like, oh no, the internet says, at this certain age they should wait total amount of. Yeah. To me, I think the internet provides is not so specific, and that's to the patient disadvantage because they take every information.
Right. Yeah, that's a very good point. I think, I remember also doing some newborn checks, and the parents, they come in and they have a lot of major concerns about if baby's gaining adequate weight. And absolutely, sometimes it can definitely be a challenge. By the same token, I think for me, the internet is helpful in the sense that it will actually give patients access to the patient portal. So if patients have internet access and they can use the portal, to me, I'm like, well, that's one way that the internet can be used for me to provide good, solid information that I would like to convey, to the patient. So then the information that I provide sort of competes with maybe some misinformation that they get, or it helps clarify some of the information that they get. Patients, they may share their thoughts of what they may get from the internet in the patient portal when they message me, and that gives me an opportunity to help clarify. So from the internet, they'll be getting other sources, but then they'll be getting information from me directly too, by using the patient portal. And of course, you need internet access for that. So, but like Dr. Biemi said, that requires a lot of effort. It does require effort. I definitely acknowledge that for sure. I would agree. So, all right, guys. Well, I think that about rounds out our session for today. So any last questions before we sign off?
No question for me.
Okay, sounds good. All right, guys. So if you guys are still on the rotation, or if anybody else, any of our current assistant physicians who are volunteering, you've got an invitation for next week. So we'll look forward to. Does anybody else plan on joining us for next week?
Yeah, me and all my group. Yeah.
Oh, who was that?
Did you say this platform on next week Sunday?
Yeah, next week.
For sure. I joined like 2 weeks ago.
Yeah, I just want to make sure I'm not all alone. So okay. All right, guys. We'll look forward to next week then. But otherwise, it was a pleasure today. It was a lot of fun. And looking forward to next week.
And Dr. Murad, just a quick question. If I have to send a request for a letter of recommendation, I have to send it through ERAS.
Yeah, it's got to be through ERAS because
to your email?
It's contact@themedinaclinic.org.
Okay, got it. Thank you. Thank you so much.
No problem. All right, guys. Very good. Well, again, it was a lot of fun today, and we'll look forward to next week. So you guys take care until then.
Thank you very much.
Thank you. Bye-bye.
Thank you, everyone. Bye.
Bye-bye.
Thank you. Have a nice one. Bye.
You too. Bye-bye.